مجهودك في النساء، انا عارفه ان انت متعذبه في النساء. شكرا على مجهودك، اتفضل.
Bismillahirrahmanirrahim. My talk today will be about PET MRI as a new horizon in gynecological malignancy. The talk outlines will be about what's PET MRI, technical background of PET MRI, imaging protocol, indications of PET MR in gynecological cancers, and the take-home message. First, what's PET MR? PET MR is a hybrid imaging modality composed of PET and MR. The aim is to combine the exquisite soft tissue contrast, adaptable field of view, and functional information of MR with the physiological imaging property of the whole body PET. Technical background. At present, PET MR imaging systems can acquire MR and PET data either simultaneously, hardware-based image fusion, or sequentially, retrospective software-based image fusion. Integrated PET MR imaging system simultaneously acquire PET and MR imaging data, allowing concurrent imaging of the same region within a single gantry, housing both the MR and PET scanners. In the sequential PET MR imaging acquisition, spatially separate individual PET and MR imaging scanners are connected by a common moving table that functions to reduce changes in patient positioning between imaging acquisition. The protocol, we take sequences for whole body, which are amdexon, T1 spile gradient echo, T1 turbospan echo, and T2 imaging fast sequences. And for pelvic sequences, we take T2 high resolution imaging, diffusion weighted imaging pre and post contrast T1. What are the indications of PET MR in gynecological cancers? We will come first to uterine cervical cancer. Of course, local staging of cervical cancers, one of the important referrals for PET MRI. This is a case of locally advanced cancer cervix. As we can see here as the point arrows, this is a cervical mass invading the lower uterine corpus. Also, there is invasion of the bladder. Okay, this is seen in both anatomical imaging in the post-contrast images and the physiological imaging with marked increase in uptake, and the diffusion is lower down. Diffusion is lower down, showing marked diffusion restriction, indicating backed cellularity. Also, this case having positive lymph nodes, pelvic lymph nodes, and positive lung nodules. Okay, monitoring treatment response. This is a case of locally advanced cervical cancer pre and post therapy. As we can see here in the first images, there is a large soft tissue mass rising from the cervix, and after therapy, the mass markedly regressed inside, yet the anatomical imaging can still see the mass lesion. So there is less sizable tumor or not, but the functional imaging show that there is no corresponding activity on PET MRI, and this was a complete pathological response proved on surgery. Assessing cancer recurrence post-surgical fibrosis, one of the challenging cases came for discriminating cancer recurrence from post-surgical fibrosis. Here are two different cases. The first, after resection, surgical resection of a cervical cancer, we can see the vaginal vault. There is no sizable masses to account for recurrent lesions. But here on PET MRI and MPET, we can see a focus of uptake of FDG uptake metabolically hyperactive lesion, which corresponds to a recurrent lesion proved later. And this is another case in which we can see irregular soft tissue at the surgical bed. This soft tissue is very metabolically hyperactive and proved also to be a recurrence. As regarding the prognosis and the prediction of treatment response, the volume of tumor burden is correlated with the overall survival after radiation therapy. High maximum SUV in both the primary tumor and metastasis has been shown to predict unfavorable prognosis. As for endometrial cancer, as we can see here, there is a metabolically hyperactive endometrial mass lesion invading the myometrium, and we can see on the anatomical imaging of the MRI small lymph nodes. Based on the size alone, they are not suspicious, but on PET MRI, they have taken up the FDG, so they were wrote to be suspicious and found on surgery to be suspicious. As for ovarian cancer, it can detect primary malignancy, peritoneal metastasis, and distant metastasis such as this lung nodule. The question is PET MRI versus PET CT. What is better to do, PET MRI or PET CT for gynecological malignancy? We can see here in the first row, in the proximal row, we can see this is a PET CT images, and if we compare the CT here in the middle to the MRI, we can definitely see the mass lesion, the malignant cervical lesion by CT. In contradistinction, in the MRI we can see the mass obviously and on the fusion and also on the functional imaging. There is questionable invasion of the bladder on CT, but it's proved on MRI. This is another case on CT. On PET CT, there is a focus of uptake in the left perirectal space, okay, and it was a query if this is a positive lymph node or it's part of the intestine. PET MRI was done later, and this proved to be a focus of fibrosis after regression of the SUV. This female patient, 53-year-old woman, after cytoreductive surgery for ovarian cancer, yet the patient still had elevated cancer antigen 125. Okay, CT was negative for malignancy, no uptake on PET CT, yet on MRI, due to the resolution, the excellent soft tissue resolution of MRI, we could detect small lesions, small peritoneal deposits in the Douglas of pouch. A take-home message: gynecological malignancies remain a major health concern, and imaging plays a critical role in directing management. MRI provides high-resolution images for staging or characterizing primary tumors, and PET provides increased sensitivity and specificity for detecting nodal and distant metastases. Simultaneous PET MRI provides all the benefits of both modalities in a single imaging session, and with the promise of improved registration, embedded motion correction, and greater diagnostic confidence due to improved soft tissue contrast for whole body imaging than PET CT. Finally, thank you.
ثانك يو دير دكتوره مروه. ممكن دكتوره نيفين تقول بقى التوب بتاعها دلوقتي، وانت تقولي التاني بعدي.